Sorry, sir. Sanmugal, sir, we are extremely sorry. We are really running
I
behind
also
schedule
wanted to
by,
ask many questions to Sriram
20
sir,
minutes.
but no time.
So good morning to all. Check, yeah. So good morning to all. Over the next 10 to 15 minutes, myself and my Dr. Gauri are going to discuss about salt sensitivity hypertension. I'm just giving you a very simple OPD clinical scenario which we usually encounter. There are two patients and both of them are same age, same BMI, both of them have hypertension, maybe same duration of hypertension, and both of them are on same treatment. For one patient, BP is phenomenally under control. Excellently, the drugs have worked for this particular patient and BP is under target. But for the other patient, BP is not under target. So we keep on increasing the dose of the antihypertensive, we keep increasing the class of drug, one more drug we are adding, and that drug again we are escalating. But in spite of all these aggressive measures what we are taking, blood pressure still remains not under control. Still it is not under control. Then one fine day, you sit with the patient, you discuss with the patient, you counsel the patient elaborately about the importance of reducing salt in his diet, and then he follows this, and then the BP comes under control. So now that brings us to an important question. While treating hypertension, are we forgetting an important phenotype which we call it as salt sensitivity? So when we understand this hidden phenotype, a very common phenotype, salt sensitivity, then that will actually change our understanding about hypertension and also will change the way we manage hypertension. What is this salt sensitivity exactly we mean? My friend Dr. Gauri is waiting to explain you what is salt sensitivity. Over to you.
Good afternoon, all. So, Rajesh had placed us in a scenario to know what is this phenotype of salt sensitivity. Let us put it very simple. If you take salt, if you reduce your BP, it means that the patient is salt sensitive. Or if the patient is going to increase his consumption of salt, again, like it is going to be put him under salt sensitivity. So it is directly proportional to the amount of salt that you are going to consume. So if your BP is going to reduce or increase by your salt consumption, the patient is going to be salt sensitive. Let us understand this basic principle. Why is it important that we need to understand? Because our salt consumption over a period of time, epidemiologically, evolutionarily, we have increased. Earlier we used to take 5 grams of salt, now we end up taking 15 grams of salt. That is the approximate salt consumption. Say, கல்யாணத்துக்கு போனீங்கன்னா தலைவாளியில வந்து மூளையில வந்து salt வச்சிட்டு sweet வச்சிட்டு அப்புறமா எல்லாம் வைப்பாங்க. But nowhere salt is being served because everything is already flooded in the food. You can't add more than that. அதுக்கு மேல உப்பு கறிக்க ஆரம்பிச்சிடும். அவ்வளவு salt increase பண்ணி வச்சிட்டாங்க. So evolutionarily we are increasing more salt consumption. So if we decrease the salt consumption in our food and if our BP decreases because of this, it means that we have a salt sensitive phenotype. Let us, with this understanding, if it doesn't decrease, the people become salt resistant. So does it mean salt resistant are better than salt sensitive?
Yes. So very clear explanation. Reduce the salt, BP reduces phenomenally, then probably that is salt sensitivity. On the other hand, the other way is also true. When you increase the salt intake, the BP phenomenally increases, and again, that is salt sensitivity. So who are these individuals who are at risk of developing this salt sensitivity? One is elderly people. As age increases, what happens? The kidneys cannot handle the sodium efficiently, so there will be accumulation of sodium. So what happens is that because of that, even subtle amount of increase in the salt again will phenomenally increase the BP. So that is elderly population. Then you have people who have diabetes. What happens in diabetes? There is insulin resistance, there is hyperinsulinemia, and there is a tendency to develop early diabetic nephropathy. So all these things will impair the sodium handling, and again there will be retention of sodium, which again will increase the blood pressure. And again CKD. And in CKD, we know that the nephrons are reduced, the functional nephrons are reduced. Obviously, the kidney cannot filter more amount of sodium. There is volume overload will be there. And again, hypertension in patients with CKD is phenomenally because of the increased volume. So again, these are the people who develop salt sensitivity, who have salt sensitivity. Obesity, there also there is impaired handling of sodium. And again, these people also are all more sensitive to salt. And you have something called as the low renin phenotype. Low renin hypertension. What happens? When there is low renin, obviously the volume is more, and when the volume is more, obviously there is more salt retention, and these patients become more sensitive to hypertension. And there are people who take high amount of salt, not only in the diet what Dr. Gauri said, but there are also hidden salt intake. We take a lot of pickles, we take a lot of puppets, and they take processed food, ultra processed food, packed items, all these things contain, restaurant food, all these contains high amount of salt intake. So these people who take high salt intake, then they are also sensitive to salt. And again, there are phenotypes. Usually the American African phenotype is more sensitive to the salt, but again, we are also not exceptions. Even the Asian phenotype, Indian phenotype is also exceptions. They are also highly sensitive to the salt. So these are the high risk individuals where we find salt sensitivity very often.
So what actually happens in salt sensitive? So Rajesh said that what are the people who are all predisposed? What actually happens? Why should somebody salt should behave like this? That is the curious question. Why it increases? Why the BP increases? Now let us understand the nephron for a minute. Edwin sir is there. He will explain us in later in his comments. So what actually happens? Let us say a normal individual. For him, whatever salt that gets filtered, proximal convoluted tubule and loop of Henle and all going there. In distal convoluted tubule, 10 to 15% of sodium comes to the distal convoluted tubule for a normal person. If he increases more amount of salt, say in distal convoluted tubule, we have this sodium chloride channel, NCC channel is there. These are the ones which are going to absorb the salt. Okay. So if somebody is increasing the salt consumption, what happens? More amount of sodium will get filtered. So this extra salt which is getting filtered is going to stimulate the NCC, it is going to inhibit the NCC channel. The extra amount of salt that we are going to consume, it is going to get filtered more, is going to inhibit the NCC channel, whereby more amount of salt will get filtered out. So there is a compensatory mechanism that happens. But actually what happens in a salt sensitive individuals, this NCC channel, sodium chloride channel, is going to upregulated. So because of this upregulation, more amount of salt is going to get absorbed in the distal convoluted tubule. If more amount of salt which comes over there, we have the other channels which is through the basolateral membrane, it is going to pump into the circulation, and more amount of salt is available in the body. Okay. So what happens if more amount of salt is there in the body? Wherever salt is there, it is going to retain the fluids. It is going to retain water. Just to open the salt and keep it, will get absorbed. Water will get absorbed. கடல்ல ஏன் தண்ணியா இருக்கு? தண்ணி இருக்கிறதுனால உப்பு இல்ல, உப்பு இருக்கிறதுனால தண்ணி இருக்கு. We should understand this. So wherever whatever is there, it is going to take water. Or let us take the simple experiment. Osmosis, we say no. Take a pot and put a semi-permeable membrane, and in one compartment if you put salt, water will get retained against the semi-permeable membrane into the compartment where salt is there. So obviously wherever there is salt, more fluid is there, more cardiac output will be there. Because of this more cardiac output, what will happen? The BP is going to get elevated. This is the renal angle of what we see. But always this renal angle is not the only one which is going to work. Always the body tries to compensate. So what is blood pressure? Blood pressure is cardiac output into peripheral resistance. So if cardiac output increases, what does the compensatory mechanism do? The peripheral resistance tends to decrease so that the BP is getting maintained. So when someone increases the salt consumption, or in a salt sensitive individuals, what happens? How this peripheral resistance gets decreased? It is mediated through the production of nitric oxide. What does nitric oxide do? It causes vasodilation. The vessel increases so that the more amount of fluid gets accommodated. Or what happens? The peripheral resistance decreases so that the compensatory phenomenon happens. Now when you consume extra salt, the vasodilation doesn't happen. Also the peripheral resistance increases, whereby the extra fluid doesn't get accommodated at all. So in a salt sensitive individuals, the nitric oxide production is also going to be less. The peripheral resistance is going to be increased. So the blood pressure again in turn increases. So three things that we need to know. One is what happens to the NCC channel, it gets upregulated. What happens to the nitric oxide, the production is less. The total peripheral resistance is going to increase. Because of this, the patient has got a high blood pressure. This is what salt sensitivity does to the individual.
Yes. So Dr. Gauri clearly told what is the pathophysiology which happens in these people. What are the consequences? What happens when a person is salt sensitive? What is going to happen to that particular person? Obviously, you can see the CVD, the cardiovascular disease is going to be increased in these people, irrespective of the BP. You have salt sensitive group of people, you have the other group of people who are salt resistant. Even though if they maintain the same BP, what happens? Still in people who are salt sensitive, the CVD increases. CVD means what we refer to all the cardiovascular, even stroke, it could be heart failure, anything. All these things get increased, and these are the people who developed easily the target organ damage, the LVH and all the other target organ damage which is relevant to hypertension will be more in these people. And again, CKD. CKD will be very, very common in these people who are salt sensitive. And again, resistant hypertension. This is very important. Most of the cases when we see the resistant hypertension, most of these people will be actually salt sensitive. And rather than increasing the medicines, probably when you reduce the salt intake itself, probably most of the cases the blood pressure will improve in these patients. But what is more important is that even for normotensives who have still not developed hypertension, if these people are salt sensitive, then the complications, all these complications are more in people who are salt sensitive, even though if they have not developed hypertension, which means even before the development of hypertension, people who are salt sensitive, they are at a high risk of developing these complications. Yes.
So how are we going to diagnose people who are salt sensitive or not? One way is like you can, the conventional way is we can reduce the salt and see whether they are responding or not. But the most important which literature says is these are all experimental, reducing the salt and seeing and all. Literature, if you see, there are n number of articles which shows that the early morning BP is related to salt sensitive people. So when you measure the BP, don't go with one. Now we all do home blood pressure monitoring. We all tell our patients to do the home blood pressure monitoring and come. But please remember, when you do the home blood pressure monitoring, one reading should be taken early in the morning. The moment the patient wakes up, ask him to go to the loo and come. Not that he can brush, he can empty bowel and everything he can do. Because he has to empty the bladder, because if he is full bladder, that itself will rise the BP by about 6 to 8 mmHg. So he has to empty the bladder and see the early morning BP. If the early morning BP is going to be more than 130, so normally if you do home blood pressure monitoring, it is 135 is the reading. So when you do early morning BP, it should be 130. If the early morning BP is conventionally, if it is more than what is there in the daytime, then think about these are the people who are salt sensitive. So this has been very well documented in the literature.
Absolutely, that's an important point. Early morning BP is very, very important. Otherwise, how do you diagnose it? You don't have any laboratory investigations. Just go to a lab, order an investigation and find out whether this patient is salt sensitive or not. The phenotype, you should have a high index of suspicion. And as Dr. Gowri said, early morning BP is an important thing. BP variability with the diet, that is another important point. And again, the phenotype. See, people who are obese, who have CKD, who have diabetes, who are elderly, all these people you have to have a high index of suspicion, and even reduction. See, what you can do is that judiciously and strictly you can reduce the salt intake for a period of 2 to 3 weeks, and with that, if the patient is having maximum response with reduction in BP, then probably these are people who are all salt sensitive. So otherwise, you don't have any hardcore investigations to actually bring out whether the patient is salt sensitive or not. Yes.
So what are we?
Yeah, going to the management, how are we going to reduce it? For the lack of time, I'm just rushing through. The treatment is salt sensitive means what we have to do? We have to reduce the salt intake. And Dr. Gowri told what is the amount of salt they have to reduce it. It is less than 2 grams of sodium, which means less than 5 grams of your salt, common salt, so what we are taking. So that is very, very important. And again, that will bring up another question, which salt is better? We have so many salts. We have rock salt, we have iodized salt, we have the Himalayan pink salt, so many salts are there, but basically understand the composition of sodium is almost similar. There are only subtle differences between these things. So any salt you can use it, only thing you have to reduce the quantity. So that is important. And more than, you ask most of your patients will be telling that they will be taking less salt. But what happens is that the hidden salt is very, very important. I told you where are the hidden salts come from, restaurant foods and all the processed and ultra processed foods, all these things they have to reduce it. They have to bring about good amount of weight loss, 5 to 10% of weight loss. There will be phenomenal improvement in the blood pressure and DASH eating time. I am not going to go into the detail, just any drugs here, it is going to be helpful.
So, the one drug which we are here to talk about is this chlorthalidone. we said three mechanisms are important. One is what is happening? The NCC activity gets increased. We said salt sensitive individuals, the NCC activity which gets increased, so extra amount of salt is getting absorbed. So this is blunted by chlorthalidone. That is one point. Second point is, we said the nitric oxide, it is going for vasodilatation. So what actually does is chlorthalidone, it increases the production of nitric oxide, whereby the vasodilatation happens. The third thing which we discussed is the total peripheral resistance increases. Chlorthalidone is going to decrease the chlorthalidone. So one drug which we all has to think about this salt sensitive individuals is placing them on chlorthalidone. That is the reason when ADR, most of the guidelines when we talk about resistance hypertension, they always say that chlorthalidone has to be one drug which has to be there in your treatment arm, so that we can say whether the patient, unless it is there, we can't tell like whether the patient has got resistant hypertension or not. So of the three drugs that you are going to use, one drug has to be chlorthalidone. Only if in spite of the patient is there with the chlorthalidone, then only we can tell them that the patient has got resistant hypertension. That is another important point when we talk about therapeutic intervention.
Yes, yeah, that's all. I think for lack of time, we'll close.
So if there are quick questions, one or two questions are coming from...
We can take it at the backstage.
Edwin, sir.
Okay, any one question, quick fire.
Sir, any one quick comment, sir. Edwin, sir, please.
Sriram, sir.
Both of you did very well on that. Two things. Not all CKD patients have hypertension. There is a significant number of patients who have interstitial disease, which is polyuric blood pressure on the lower side. So uniformly restricting salt for all CKD patients is not necessary. Most diabetics, of course, it's a salt retaining state. This is number one. Number two, regarding the salt substitutes, patients come and give us some names and say this salt, that salt. There are a lot of salts that contain more potassium and less sodium. And potassium, is detrimental whenever a patient has a kidney disease. So these two are very important points. And remember, chlorthalidone, wonderful drug. However, in the very elderly people, be very careful with the use of chlorthalidone. It's long acting. And in patients who there is a salt restriction with a diuretic in a hot climate like this, can predispose to hyponatremia. So please be careful. Thank you.
Sir, one more thing, do you feel in the role of magnesium supplements in this salt-sensitive hypertension as an adjunct or supplement? Magnesium supplements for...
Regarding the salt substitution, iodization is not there for those salts. So all this pink salt, Himalayan salt, iodine kadayadu. So don't take that for that reason, from our thyroid and other reasons. So morning we discussed about public health policy. Salt koraikano, ana adu iodine irukra salt koraikano.
Thank you, sir.
Yeah, thank you, sir.
Thank you, sir.
Thank you, chairpersons, and thanks to my dear friends Rajesh and Gowrishankar. For the next talk, Time to Think, I would like to invite chairpersons Dr. Ranjit Pratap, Dr. Priya Malini, and Dr. Sethuraman.